Good morning, fellows from East Coast, West Coast, and around the world. One day I will get that right for Dr. Jane Spangler. Welcome to our next session of our Fellows Project, focusing on bariatric surgery and patients interested in fertility, pregnancy, lactation. And so we have some fantastic speakers. Before we get started, let me give you some announcements. We start ASMBS this weekend, and there'll be some great sessions. Focusing on the fellows, we have a fellows reception that is going to be hosted by the Bariatric Surgery Training Committee with some sponsors on Tuesday at 6 p.m. It's at the Marina Ballroom D, the Marriott Marquis. It'll be in your ASMBS app, which is now available. This start, our robotics training program, we'll have a session from 8 to 9:30 in the morning on Wednesday. And then for those fellows who participated in the START program, we will have our graduation from 1 to 125 in the exhibit hall. And you guys should be getting an email if you haven't already from Morgan, the woman, the myth, the legend that makes sure we're all on track. Now, moving forward, we have Dr. Renee Hilton. She'll speak first. She is an associate professor in Augusta, Georgia. I'm going to call it Medical College of Georgia because, of course, I just blanked on what the change in the name was, but I apologize. She's also the director of bariatric surgery and a section chief for minimally invasive and bariatric surgery at MCG. And she chairs the Access to Care Committee, who just had their first fellow member. And we're really excited about having her here today, as this is something she's been passionate about and teaching about for a while. And actually, we thought of the idea because of some of Dr. Hilton's comments and discussion at the conferences. We are also joined by Dr. Richard Peterson. He is a full professor at UTL Science Center in San Antonio. He's the director of bariatric surgery, and he's now the vice president, soon to be president-elect of ASMBS. So we just have some giants here today for you guys to teach. Dr. Wilson will be moderating with me today. She is joining us from Cleveland Clinic, and she will be a face with me moving forward. And I look forward to you guys getting to know her, as I do as well, with moderating our questions when we're done. So make sure you put your questions in the Q&A, and we'll go from there. Dr. Hilton, why don't you take it over?
All right, so I'm going to try to do this easily. I'm going to share my screen. Okay, excellent. All right, so I'm so excited that you guys are getting to hear about this topic as part of your fellow education, because I think it is a really important one that sometimes get glazed over. But hopefully by the end of mine and Dr. Peterson's talk today, you guys will be convinced it's a really important topic. I have no financial disclosures. Dr. Peterson has disclosures from Teleflex and Standard Bariatrics, but they have no relevance for today's talk. So our objectives are to cover three very important topics in women's healthcare as are related to metabolic surgery, and that includes fertility, lactation, and pregnancy. So I like to think of this as three phases, right? The before, the during, the after, all centered around, pregnancy. So the first topic we're going to talk about is fertility. And the objectives for that are to discuss the benefits, one, of metabolic surgery on a woman's fertility, review contraception recommendations at the time of surgery, as well as contraceptive recommendations after bariatric surgery. We're going to talk a little bit about PCOS and how surgery affects it. And then how basically you, when you get out and you join whatever center you're going to, you can help better support women interested in bariatric surgery who are of reproductive age and have questions regarding this topic. And then I'll give you a brief overview of what our center is doing, because I think we're doing this really well. There's also a section at the meeting, if you guys are coming to San Diego, entirely on fertility and sexual health for both men and women. I encourage you to join us for that. So women's health and obesity, what is the impact? So as you know, 80% of bariatric surgery patients are female. I think by now as fellows, you've probably seen overwhelmingly most of your patients are female. Well, 50% of them are going to be of reproductive age. So this is absolutely a topic that you're going to need to be familiar with. Obesity can impair their fertility, maternal health, maternal obstetric outcome, fetal outcome, benign GYN health, and cancer. It basically affects every part of the women's reproductive health. And then ACOG has come forward and actually recognized metabolic and bariatric surgery as a promising pre-pregnancy obesity treatment. Get to know your OBGYNs wherever you end up practicing. They will be a steady source of referrals for you. When we first started doing a lot of things that I do together with our OB group, one of them told me there is no scarier place than an OR where you're doing a crash C-section on a BMI of 70. It's frightening. We really want to help these women. And so that kind of is what led to my partnership here. But first, to talk about fertility. So there's an increased infertility among women with obesity, and this is largely attributed to the co-occurrence of PCOS. So I'm not going to go completely down the PCOS rabbit hole today because I feel like that is an entire lecture. And again, if you come to San Diego or watch it online, we have a lecture on this. But it's characterized by hyperandrogenism and anovulation, which is often accompanied by insulin resistance. So you get this vicious circle where women are not ovulating. They have hyperandrogenism, insulin resistance increases, and we know that insulin resistance then goes on to further worsen the cycle of obesity. So weight loss among women with obesity and with PCOS helps restore ovulation and chances of conception. I'm very careful with how I counsel these women because some of them will tell me, oh, I don't need to worry about contraception, Dr. Hilton, I have PCOS. I've been told I can never get pregnant. Well, that may be true before metabolic surgery, but not necessarily after it. So I then get the other question from both OBGYNs as well as patients is, well, is it safe to get pregnant? You're telling me I can get pregnant, but how safe is it? I love this study from 2018. They basically looked at delivery outcomes and term births after bariatric surgery. This was a matched cohort study. They controlled for everything under the sun and compared women who then went on to get metabolic surgery with those who did not, that were equally matched. And the answer is we make everything safer. Literally almost everything. There's one category we'll talk about a little bit later that there may be higher risk in, but post-term pregnancy, induction of labor, epidural analgesia, labor dystocia, fetal distress, peripartum infection, oasis, that's anal tearing, sphincter damage. I had to look that one up. Scary category. Postpartum hemorrhage, all were substantially lower and statistically significant in women who had bariatric surgery. So yes, it's safe. As a matter of fact, it's actually safer. So what are the concerns with post-bariatric pregnancy? Well, one, rapid weight loss. So this is usually in women who get pregnant really fast after bariatric surgery. If they wait the appropriate amount of time, we don't worry about these as much. But if you have a patient who gets pregnant in the first 2 to 3 months, we counsel them on the fact that rapid weight loss can be associated with vitamin and mineral deficiencies. And some of these are, very important for fetal development. We'll talk about them on the next slide. But for this reason, we really recommend, or the ASMBS as well as IFSO recommends, a contraception in the postoperative period and delay of pregnancy for at least 12 months after bariatric surgery. For your boards, for the purposes of this talk, 12 to 18 months is your answer. We are pushing this in our program. We say stable weight loss in labs, as long as our high-risk OBGYN agrees with us. And we have allowed some women who were in their mid-40s who were really concerned about their biological clock and time running out. We've allowed them to start trying at 6 months when the sole purpose of metabolic surgery was to improve their fertility. Again, special circumstances. So what if they do get pregnant early? Those nutritional deficiencies I talked about, iron, folate, B12, calcium, and vitamin D, we see that a lot in postoperative bariatric surgery patients. But when you have a developing fetus and you have some of these deficiencies like folic acid, vitamin D, you can look at things like neural tube defects, rickets, pretty severe fetal complications if you do not correct and adjust these deficiencies, some of which are fatal. But nutritional supplementation and close monitoring of their nutritional status, both preconception, during pregnancy, and after, I think can be done very safely and is crucial for a bariatric surgeon and a high-risk obstetrician to do together. So what are options for contraceptions? We avoid oral contraceptions in our program. I've had bad experience with them. One, they increase the risk of VTE. But also if you use contraceptive implants, they have been shown consistently to outperform their oral counterparts. ACOG encourages long-acting reversible contraception. So these are your IUDs and things like Nexplanon, the little matchstick thing that goes in their arm. And then last, I'm going to tell you that this study is an old one from 2010. This study changed my practice. When I read this study, I was preparing to give a talk to a bunch of OBGYNs. And as I read it, I just couldn't believe the numbers. And if you look at these numbers, this is a survey that was sent out to bariatric surgeons. And only 56% of male surgeons, 49% of female surgeons stated they did not even require a pap test or mammogram before surgery. Only 21% had ever even referred a patient for endometrial evaluation, even though we know how at risk for endometrial cancer our patients are. A fifth of surgeons said that they do not consistently counsel their patients about increased cancer risk due to obesity. Female surgeons were more likely to obtain a menstrual or cancer-related history than male surgeons were. But when I looked at this and I said, holy smokes, if only a fifth of us are actually talking about cancer, how many of us are talking about pregnancy and lactation and birth control? And I knew that it had to be just even lower than that and probably pretty abysmal. So that led to, again, a change in my practice, and we created our Women's Health Initiative. This was created in 2020. We have an OBGYN as part of our bariatric pathway for women who are interested. They're all screened on their initial HPI with the surgeon, and then we arrange for their women's health clinic along with any other age-appropriate screening like mammogram and colonoscopy. They get consultation for family planning. They do this on a day when, again, they're already here for like an RD appointment for our bariatric program. And some of these women they haven't seen an OBGYN in 20 years because of the stigma associated with obesity. They're embarrassed. They didn't want to go, or maybe they had a really bad experience in the past where someone couldn't perform a pap smear and told them, well, you're too big. So what we want is for our women to never have that kind of experience. We want them to experience an OBGYN setting that focuses on patient first language and really treating them the way they deserve to be treated. And we've done this now for 3 years, and we're getting ready to publish our 3-year data. But we have identified hyperplasia in a 15-year-old and cancer in a 25-year-old. So I would encourage you guys to really make this a focus. So switching gears now from fertility and just kind of overall women's health care to the impact on breastfeeding. So this is kind of the after, and Rich is going to talk about the pregnancy part in a second. Breastfeeding never, I felt like, got talked about in my fellowship. I had no idea how to counsel women. And what really led me to dive down this rabbit hole is I became a mother myself. And after breastfeeding and being pregnant for, I think, over 5 years between my two girls, I feel like I'm kind of a quasi expert on breastfeeding at this point. And anyway, we know that there's lacking data for our patients. So I wanted to talk to you guys about that today. We're going to talk about the patient population again, and then I'm going to help you learn how to address this with new bariatric patients, how to introduce the topic, and then what you tell your long-term bariatric patients who've had successful surgery and are now pregnant and want to know, hey, am I going to be able to breastfeed? So first of all, there's an overwhelming lack of data. There are fewer than 20 good papers on this. So if you're a fellow looking for an opportunity, ding, 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 start writing. Most focus on pregnancy and postpartum or fertility issues. There's very little on lactation. There's none on preoperative counseling or surgeon decision-making. And I think there might have been one that came out of SAGES after this Facebook group discussion. And this certainly led to a podium being created last year, or even a session at ASMBS, and another one this year. And this SAGES Bariatric Surgery Masters Program collaboration post from Mustafa is really what started it, because, kudos to him for having the courage to say, hey, I've looked in the literature. I've thoughts about performing a sleeve on a patient who's breastfeeding. What do I do? And you can see there's 32 comments from people around the country that have dealt with this before. And really, it was a great conversation. I encourage you to even go find that post and read it. But again, why should you care? This is the data published. I think this was, Ben Clapp and Omar's paper, looking at the past 5-year data in ASMBS. I've already told you this before, but when you look, 80% of your females are going to be, or 80% of your patients are going to be female. And in terms of age, our mean age was 44. So a lot of your patients are going to be reproductive age, and breastfeeding is really something that you may need to talk about. So I'm not going to do a pro breastfeeding talk today, but I will tell you just about why it's pro for metabolic surgery. That everyone knows there's numerous health benefits for both mom and infant, but the maternal health benefits in terms of obesity are actually pretty profound. And I didn't realize this until I prepared these talks, but there are maternal health benefits that decrease risk of obesity, diabetes, hypertension, heart attack, hyperlipidemia, breast and ovarian cancer, all real concerns for our patients. You also see an earlier return to pre-pregnancy weight, as well as a decrease in postpartum bleeding. So lots of benefits to metabolic surgery patients who elect to breastfeed. So we should be supportive. I think that there's the initiation and duration of breastfeeding is lower on average in women who are overweight and women with obesity. Maternal weight loss after bariatric surgery and breastfeeding can reduce the risk of overweight and obesity in their children. So when you look at this, the rate of obesity in children dropped by 52% just after bariatric surgery for the mom. So again, there's lots of things that I wasn't kind of expecting when I started reading these talks. You can have a profound impact, not just on mom, but even future children. So really kind of the meat of this talk is you've got a new patient in your clinic, and maybe they walk in and they've got like a 1-month-old baby with them, and they're, there to talk about metabolic surgery. How do you introduce the topic? How do you tell them what will be the impact of bariatric surgery if they're currently breastfeeding or postpartum? How will it impact their diet, their milk production? And then for perioperative patients who just say, I want to do bariatric surgery and I'm going to continue breastfeeding, how do you manage breastfeeding post-op right after you do a sleeve or a bypass on someone? Because you will occasionally get those patients as well. So this can be an awkward thing, right? To just start asking someone, hey, are you breastfeeding? However, if you do it as part of routine questioning in your women's health portion of your HPI or the ROS, it becomes routine. Every woman with obesity should be screened by their metabolic surgeon. I'm saying this loud and proud. Everyone listen. Every woman should be screened to avoid missing obesity-related cancer, assist them in family planning, and offer her a referral to a women's health expert if needed. Adding a couple more women's health questions, like we've done in our WHI, I think really brings this home. And what I do is I just simply ask them if I know they've recently given birth, or if they start talking about, wanting to give birth, I talk to them about, are you going to want to breastfeed? Let's talk about that. And the reason that you need to talk about it is their supply will tank. If you have a woman who's breastfeeding and you put them through, or they go through bariatric surgery, the number one reason for a decrease or cessation of supply is due to dehydration or an increased need of high fluid volume. So if you've ever breastfed, I can tell you that the volume of your milk production in a day can fluctuate greatly just because you're in a long case. I know this as a surgeon, and maybe you're a liter short on taking in your fluid, or even 24 ounces, a bottle of water, you may see a drop in milk production. We know that our patients really struggle to get in fluid. So most of us who've been doing bariatric surgery have seen that all of our patients that we've done it on, they have not been able to maintain at least enough supply to fully support their infant's needs. There also is a need for carbs and extra calories when you breastfeed. Most people quote 500 to 1,000 kilocalories a day. Acute weight loss and ketosis also affects supply. So when you look at all of these things, we're cutting their calories. We are putting a lot of them into ketosis early on, and we know they're going to have difficulty maintaining fluid, and they're going to have a huge amount of weight loss in those first 3 months. Everything we do after metabolic surgery can decrease supply. So that's one of the reasons that we think you have to have this discussion. So timing is everything. If I have a woman that comes in and she's got a young child with her, I ask her if she's breastfeeding. If she is, we talk about goals. What are your breastfeeding goals? How long do you want to breastfeed? How old is your child now? What's your weaning plan? If your baby is ready or near weaning, are you willing to stop breastfeeding to pursue metabolic surgery? And then what is mom's insurance requirement, and what's the rush? So all these things are important, because if you have a mom in your office who's got a 6-month insurance plan, so she's going to have to be in your program for 6 months. Infant 6 months old, mom tells you, my goal is to make it to 1 year and then I'm comfortable stopping. Well, then fine. Maybe you don't need to delay metabolic surgery. You can go ahead and enroll in your program. But if mom is in your office, and I've had this happen where I've literally had women come in that are 6 weeks postpartum with this itty bitty baby that they're actively breastfeeding in my clinic. And that's when I think you need to say, what's the rush, mom? What are your goals? And if mom's saying, I want to breastfeed my child until they're at least a year old, I honestly think you need to have a realistic conversation with that woman about delaying the entry into the metabolic program until she's ready to stop breastfeeding. I will say this, breastfeeding is a lot. Metabolic surgery preparation is a lot. I do not know if you want to combine that amount of stress on a new mom it may not be the best time to put them through the rigors of a metabolic program. So again, just have this conversation. The most important thing is listen to her goal, find out what's the most important thing to her. I will also tell you there's a little bit of hormonal influence on hunger during breastfeeding. I was never as hungry as I was breastfeeding, even pregnant. I never ate the way that I ate when I was trying to breastfeed. And the reason of that, there's actually, I looked it up because I was like, why am I so hungry all the time? Prolactin actually stimulates hunger and it can stimulate weight gain. So the metabolic effects of prolactin also should not be ignored. For someone who is in a pre-op program, it may be really hard for them to lose any weight pre-op or control their diet. So lastly, I just want to say, empower your patients, have a discussion, educate them and tell them what's likely to happen if they do go through a surgery. Listen to her goals and make a plan. Even if that means delaying surgery by 6 months, I still think doing what's best for her and her baby is the right way to approach this. So now you have a woman who says, you know what, Dr. Hilton, I don't care. Like if it tanks my supply, I still want to go forward. I realize I have a 6-week-old in your office. I want my sleeve and I want it in 6 months. Okay, so we're moving forward with metabolic surgery, and she wants to try to continue breastfeeding despite the fact that she may not be able to. So what I tell my patients, and this has come up way more often in gallbladders than anything else, there's no need to pump and dump except for very, very select circumstances. And I have a slide that's a good picture slide in a second. But what I tell them is when you're awake and stable enough that you can hold your infant, it's safe to resume breastfeeding and pumping. So I educate patients. I tell them to bring their pump to the hospital. Sometimes the hospital will provide a pump, but not everywhere. So I tell them, make sure you bring your supplies if they're going to be admitted. Because even if they cannot breastfeed the infant, maybe they can pump while they're in the hospital to maintain their supply. Pump and dump, the answer is no. This is a great picture graphic from anesthesia literature that shows the majority of medications that we give, you can directly proceed with breastfeeding afterwards, even, most opioids. Meperidine is a strong red, avoid. And then the yellow ones say monitor closely or no data. I do not let them immediately breastfeed with these just because there's no data. And so what I do is in our ERAS program, we give patients ketamine. If they're breastfeeding patients, we skip the ketamine and use something else just because there is no data with ketamine. So again, their fluid requirement is going to be higher than normal metabolic postoperative patient, and they're probably going to need increased caloric needs to account for making milk. So just take that into consideration when your RDs are planning a postoperative plan for these patients. This was looking at long-term bariatric follow-up patients. Again, there is no literature, but I will tell you that what all of the literature suggests when you delve into it is our patients have all experienced judgment about wanting to get pregnant or breastfeeding or moving forward after bariatric surgery. And they all feel that their providers, whether it be OBGYNs or bariatric surgeons, are not educated enough to educate them on these topics. So again, please educate yourself, have meaningful conversations with these patients. Tell them that with monitoring micronutrient supplementation, family planning and nutrition planning, breastfeeding advice, they can do this. They should not be experiencing attitudes of judgment or lack of knowledge for survivors. So the last question is, can it be done? I was only able to find 2 abstracts that showed percentages of what women after bariatric surgery were able to breastfeed. And the data is not great, meaning most of them can't. 86% of patients in one abstract had to supplement with formula. And there were 2 reasons. One is maybe they didn't have inadequate milk supply. But also, if you think about what happens to the breast of a lot of our patients after metabolic and bariatric surgery, they lose a lot of weight, and a lot of that can come from breast tissue. And it may have difficulties with latching, meaning the infant's not able to latch onto the nipple appropriately. So some of that cannot be avoided. I tell all of my patients, you will have loose skin. If you lose 150, 200 pounds, there's no way not to really have some loose skin. So they did find this to be a problem in some women. Both of the abstracts did again call for greater health profession education regarding the care of pregnant and lactating women prior to bariatric surgery. And women said the advice they were given was inadequate. So again, I cannot thank ASMBS enough for bringing these topics to the foreground to educate our fellows and physicians at conferences, because we need to be learning more and having, these conversations. Last thing I threw in there, it wasn't on the agenda, but this is just such an easy thing. Do not give AOMs to pregnant or breastfeeding women. Every single one are currently contraindicated. Some cause major birth defects like eusemia. Topamax is a major teratogen. But most importantly, there are no clinical trials as of yet that says it's safe. So just keep that in your back pocket. Now I'm going to transition to our VP, soon to be president of ASMBS, Dr. Peterson.
Thank you, Renee. Appreciate it. I would like to just underscore a little bit too what Dr. Hilton was saying. These patients that come to see us, oftentimes because of the stigma of obesity, we are the sort of first doctor they've seen in a long time. And so, in our program as well, we do a lot of the health screening things, pap smears and whatnot. So, and those things have come up. One of our referral basis are from our OBGYNs for endometrial cancer. So it is a thing. And so just take that into consideration as you see these patients. You may be the first person that they've seen in a long time for their health. So we'll talk about pregnancy now. And we're going to, the objectives of this section, to identify the most common surgical emergencies in pregnancy after bariatric surgery, the work of the bariatric emergencies during surgery, and identify and promptly intervene on internal hernias after gastric bypass. And at the end, I'll switch it back over to Dr. Hilton, who has a case presentation. So pregnancy in the bariatric surgery population. So in the US, 80% of our bariatric surgery patients are female, with 50% being reproductive age. And the American College of Obstetrics and Gynecology recognizes bariatric surgery as a pre-pregnancy obesity treatment. It's very possible that you're going to encounter a post-op bariatric surgery patient who's pregnant or wants to become pregnant. And to Dr. Hilton's earlier comments, in terms of fertility and patients saying, they've been trying and have never become pregnant, that sometimes is a big change, and it's a surprise to people. And so be aware, we counsel our patients on making sure they're, careful during those first few months after surgery. Most common operations that have been done in the past and their complications, we're going to talk about 3 of them: the band, the sleeve, and the bypass. Obviously, you know that the sleeve is our currently the highest performed procedure of bariatric procedures. Bands have now become in the single-digit percentages, but there's a lot out there, so be aware. And SATI, DS, and OAGB are all out there and gaining popularity, so you could end up with one of these too. So the adjustable gastric band, if you just see like this version here, first of all, the X-ray in this case, I'll point out 2 things about this X-ray. One, the phi angle of the band is at 45 degrees, so it's sitting in a good position. That port that you see there may be slightly flipped, but anyway, be aware where the ports are. But the bands themselves should be seated in this angle. We'll talk about this in just a moment. So the complications can be broken down into 2 things, both early and late complications. Early complications, the mortality rate for doing a band actually is the lowest of all the procedures that we do. Early obstruction, that's not very common, but can happen. DVT, you'll see, is pretty much similar across the board with all of them. But the late complications of the adjustable gastric band are perforation, it's very low, but band slippage is one of the higher issues afterwards. Erosion doesn't happen often, but I will tell you, anytime I get a new band patient that does come into the practice, I will do an endoscopy to ensure whether they have an erosion or not. Even if they want it just taken out, you don't want to be surprised when you get into the operating room and find that you're about to take out a band that is halfway through the stomach. Port complications, they do happen, and probably you may see some patients it may be redness or infection, which is also, just so you're aware, that should be your first sign that there's a potential for erosion, but the ports flip and things like that. So be aware patients get pain at the site. The reoperation rate with gastric banding is high. It's high, almost 30%. And be aware patients get gallstones after banding as well. So your first step when a patient comes into the emergency department or comes into your clinic has been having problems, you should just deflate the band. And so interestingly enough, the company doesn't, it's hard to get those band needles now. They used to be pretty easy to get, but it's a long Huber needle. So if you can, you want to access it with a Huber needle, but just be aware that if it's an emergency, just access the port with anything to deflate it if you can. Go ahead.
Sorry.
And the sleeve gastrectomy. So again, you're all aware what a sleeve gastrectomy is, but we're removing 80% of that stomach. We'll talk about the complications there. So there are fewer late complications with the sleeve as compared to the band. The earlier complications include leak, which is still about very low at 0.3%, but pulmonary embolism, pneumonia, bleeding, mortality. The biggest of all of them is really dehydration and readmission, which on average is about 1.3%. The late complications, small bowel obstruction, be aware that you can get a small bowel obstruction. We were surprised, even in our own practice early on. Not only just the bowel low, but one of the things you can do is develop a hernia if you're not careful and you open up that portion of the omentum posterior to the stomach, and you'll see, if you're not careful, you'll see some of that bowel poking through there. So make sure you're careful when you're doing that. Stricture rate 0.4%, and the gallstones, you can see that's a little bit higher in the sleeve gastrectomy patients than it is in the bands. And then the Roux-en-Y gastric bypass, which is going to be the focus of the last part of this. Complications, again, you see both are a little bit, there's a few more in both categories of early and late. The leak rate is still under 1%, and the bleeding rate's about the same. Death rate, highest of the three, but still not that high. It's still at 0.15%, with the dehydration just being a little higher as well. But the one that we're going to focus on the most for these folks is small bowel obstruction, which can occur in about 2.3%, but internal hernia is about 7% after surgery. And marginal ulceration still there, high risk if you're taking NSAIDs or smokers. Stricture rates, again, that happens anywhere between 6 to 8 weeks after surgery typically. So that's something that you're going to want to deal with. Stricture rate can also occur because of stuff like marginal ulcerations. GG fistula, we don't see that as often anymore. That used to be sort of more in the era of the open surgeries, but it still can occur in our patients. And then gallstones, just about the same as the sleeve gastrectomy. So internal hernia, there is the acute presentation and chronic presentation. Chronic presentation is probably what you'll see more often than not. And those are patients with intermittent abdominal pain, and they're doing really well with their weight loss. There's weight loss without non-compliance. But the acute one is the one that's going to take you to the emergency, or take you to the operating room, in the middle of the night. They'll have epigastric abdominal pain, nausea, often without vomiting, because of course it's patients just they don't vomit a lot. Hiccups are going to be from a distended remnant stomach. You'll see elevated LFTs, and that can be because of the biliary limb obstruction. And the gastric remnant distension on CT scan and clinical suspicion. And I'll mention too, mesenteric swirling, which is the one of those signs you see the most, but it still may be missed on CT. So 2 areas. This is actually not a hernia named after me, but I do remember as a resident being pimped on that. If that's still, I don't know if that's probably a PC term anymore, but that's what it was then. So the retrorulen hernia, and again, in the retrocolic and then the anticolic fashion, about 2/3 of gastric bypasses are performed in the anticolic fashion. The true Peterson's hernia follows in the retrocolic. The other hernia is at the jejunocleidomastomy. There's different, if you depend on where you look. We put together a chapter on this. I can tell you we found that there was more at the JJ, but other studies come back and say it's more at the Peterson. So be aware. So The imaging, you can see on this left side, you see the mesenteric swirling. Again, I encourage you, and you're probably all doing this anyway, make sure you look at your own CTs. I overread CT scans by our radiologists all the time, and that doesn't mean they're not doing a good job, but I'm hyper focused on a certain thing. They're looking at everything. And so they may not see it. Now, this one's a little bit more obvious and shouldn't be missed by any of them, but you can see the dilated gastric remnant on the right-hand side, of course, all the bowel and the population there as well. So I'm going to turn this over to Dr. Hilton again for the case presentation.
Thank you, Dr. Peterson. So we highlighted all of those complications just to remind you that whether the patient is pregnant or not, those are the most common complication rates. So if you have a pregnant woman who's had a history of bariatric surgery and she shows up in your office, nausea and vomiting was listed on every single one of those complication profiles. The most common symptoms are often associated with pregnancy. Oh, she's pregnant. Of course, she has nausea and vomiting. Don't discredit that in a post-op bariatric patient, okay? So I love this case presentation because it literally highlights, I think, every part of this talk. So a 38-year-old female who presented to me, self-referred. She had a sleeve done in Mexico because she did not have access to care, no insurance. She developed a severe stricture at the incisura, barely able to get even contrast through it. So I converted her to a Roux-en-Y to address her PO intolerance and her strictures. 2 years after a Roux-en-Y gastric bypass, she was finally able to undergo intra vitro fertilization, which was successful, and she got pregnant. And I remember this case profoundly because the OBGYN who caught this patient in her clinic called me and she's like, why on God's green earth would you ever help this woman get pregnant? Her abdomen's a war zone. There's so many surgeries. And I was like, come on, like every woman deserves to get pregnant, like no matter what their surgical history is. And she's like, well, now she's pregnant and I don't know what to do with her because she also had hyperemesis gravidum. So I feel this OBGYN's pain because this was a difficult patient to manage. She had severe nausea and vomiting every day of this pregnancy for all 3 trimesters. What do you do? This is probably the ultimate complex patient, right? Well, we really stressed bariatric follow-up. We focused on her labs and nutrition. We saw her along with her OBGYN. We kind of switched it. Every month someone was seeing her. She had a high-risk OBGYN referral for someone who was a little bit more comfortable with high-risk pregnancies than that initial OBGYN who clearly was not comfortable. And then we had a multidisciplinary approach. There was lots of communication and education both ways. Every time she came into the labor and delivery ER with intractable nausea and vomiting, we were made aware and we had a conversation about how to manage it. So what we basically said is, we're not going to scan this woman every single time she comes in and she's vomiting everywhere. We have to make a plan or else we're going to end up with 100 CT scans or MRIs on this woman before she delivers. So what we said is, you can do a CT scan only if it's accompanied by irregular labs and abdominal pain. If she's just vomiting, we're not going to scan her. Our goal was to avoid scanning her, like I said, every month or week. CT scans can be done safely in pregnancy if done correctly with the assistance of the radiologist as well as your OBGYN. MRI is another great alternative. But what I learned during this woman's presentation is for the internal hernia risk, our radiologists really wanted the CT, even though sensitivity and specificity are not that different with the MRI. But we all agreed that in the 3rd trimester, we could safely scan her a couple of times when it became harder to do an exam and tell if she was obstructed because her belly, again, you're 9 months pregnant, it's a big belly. So I saw this fetus a couple of times before it got here. You can see here, very pregnant, gravidum uterus. And we scanned her this day because she did have elevated LFTs, was vomiting and had abdominal pain, and everything looked pretty good. I didn't see any swirling. There was no obstruction. We managed her. We gave her fluids. We sent her home. This is the exact same patient on a different day. Fortunately, this was in the 4th trimester. She was about 2 weeks postpartum. And I honestly think that she had such a big abdomen, the expansion of the uterus, that when she delivered, she just herniated all of that bowel through mesentery that was probably, I don't know, squished. It's not really a technical term, but that's what I think. And I've seen this twice now where in the immediate postoperative period, women come back into the L&D OR with internal hernias that gets missed. They missed this for 24 hours. They worked this woman up for every postpartum complaint possible. before finally the high-risk OBGYN came on call, and she's like, dear Lord, why haven't you guys scanned this patient yet? This is one of Hilton's patients. They scanned her. We took her to the OR. Fortunately, none of this bowel died. And she was able to continue breastfeeding, even surrounding all of this. She did end up having to supplement with formula, but she was able to keep making enough milk, even in the setting of profound acidosis. We kept her pumping in the hospital and we maintained her supply. That was important to her. So this is a haiku that I wrote about management of internal hernias and pregnancies. Operate. First trimester, second trimester, third trimester, fourth trimester, operate. Lab can be done, but a big incision is better than none. I don't know if that's really a haiku, but that's what I call it. The residents laugh at me because I say this is a haiku. If you are going to operate, I love this paper from SAGES. This is a recent update to the guidelines for the use of laparoscopy during pregnancy. This came out in 2023. There's a link to it down there. You're more likely to operate on appendicitis or cholecystitis as an MIS surgeon. However, you will eventually see an internal hernia or something related to pregnancy. Learn how to operate on pregnant women, learn where to put trocars. This is a quick read, and it may end up saving a woman's life if you're alone in the middle of the OR your first year as an attending. So in conclusion, all surgeons can expect to encounter a bariatric surgical patient. 80% of our patients are female. The majority of those are reproductive age. Acute complications must be diagnosed and treated expeditiously to achieve optimal outcomes. We thank you, Rich. I'm sorry, that's the only social media post or place I could find for you. But I love the picture. So if you want to follow me or Rich, this is us. Feel free to reach out to us and ask us any additional questions. And I think we can open it up to the chat, Dr. Wilson and Dr. Eckhouse.
Yeah, I want to introduce Dr. Wilson. Thank you for those fantastic talks, guys. Dr. Wilson is an assistant professor at Cleveland Clinic. She's the chair of the Public Education Committee and the associate program director for the Bariatric Fellowship at Cleveland Clinic. She's going to moderate the rest of the time. Take it away.
All right. Good morning, everyone. Thank you so much to Dr. Hilton and Dr. Peterson, really just for that great reminder that, you know, women desiring pregnancy and lactation are not off limits. We can be aggressive and treat them and counsel them. So I had a question to start for Dr. Hilton. Congratulations to your program for doing something that I really hadn't thought about in terms of having our OB-GYN partners part of the bariatric program, more of a multidisciplinary approach than the normal psychologist, nutritionist. How, what were the words that you used? I know someone in the chat said, hey, I'm drafting an email now to the OB-GYNs in our area, but what are the talking points? How do you even broach this subject to really collaborate and partner to take better care of our patients?
So all of this started when I was preparing a talk for GOGS. First, I gave a grand rounds to my OBGYN group here. That's where I would start. They wanted me to come give a grand rounds and talk about metabolic surgery. I have about 1 million slide decks, I feel like, on pregnancy and lactation and women and bariatric surgery. I have slide decks that focused entirely on endometrial cancer. So I gave them that talk and they were all just like, oh my God, like we need to be partnering together. Yeah. And then I got invited to go to Georgia, the GOGS of Georgia, went there and gave the talk. And then I started getting women from all over the state of Georgia. Like anyone, like all these OB-GYNs were sending me patients. And so me and the then chief of the OB section, we sat down and said, he's the one that told me there's no more terrifying place in the world for me than a crash C-section on a BMI of 70. And the big push for us in Georgia is we rank 49th in obstetrics outcomes for women in this country. And if you're a Black woman in the state of Georgia, it is more high risk for you to go have a baby than to have metabolic surgery. Wow. And that for us is just, it has to be fixed. It was actually one of the talking points I used to get access reinstated to our state employees when I met with Governor Kemp, because one of his big initiatives is women's health. We actually use women's health to get bariatric surgery added back to the state employee plan, because one of his biggest initiatives is to reduce maternal mortality, and obesity is a big factor in that. Hypertension, diabetes, all of these things. So that's what we built it on. We had the conversations around it. And then he said, I have a junior faculty member who's looking for a niche. She's looking on something to make her career. Me and that junior faculty member 3 years later just presented a combined podium at AMWA on what we're doing here. We're publishing on it. We've given countless talks around the country in GYN and general surgery and a few ASMBS talks. And I've done podcasts on it. And here recently, we've had other institutions. Finally, this is what I've been waiting on. Other institutions are calling me and saying, hey, can you help me get this started? And that's what's really exciting for me after doing some of the most recent podcasts is I'm telling this is how we did it. Here's a layout of how you could replicate it. Because that's what I want. I want this to be a standard, a part of care for women in our country. I want the ASMBS to write guidelines on it. Like I want this to just be part of how we take care of women. Sorry, very passionate answer.
Yeah.
Rickesha.
No, yeah, thank you. I think that's great. And so the main concern that you see from the obstetric and gynecology community is just high BMI. They would rather have these patients treated first, if possible, before pregnancy and all that care.
That, and they become the primary care provider for a lot of these women.
Yeah.
They are the ones treating their obesity, they're treating their hypertension, their diabetes, their sleep apnea. And you saw all of those complications during childbirth are reduced with bariatric surgery. So I think for this provider in general, he's a high risk OB. He gets the worst of the worst deliveries. For him, it was all about the delivery room. That was first. But then he also was like, all this other stuff is going to benefit from it as well. But he was saying, I want to send patients to you postpartum. Can I send you patients to you while they still have Georgia Medicaid for pregnancy? So we really pushed the envelope. A lot of these women didn't even have bariatric coverage, but they did while they had pregnancy Medicaid. So we beat the system.
Wow.
We would get them in and see them under pregnancy Medicaid and then encourage them to stay on Medicaid or get insurance that had bariatric surgery. So we were getting them in while we had an access loop or loophole, if you will. Yeah, that was, again, we really pushed all sorts of envelopes with this, and it has become one of the most meaningful parts of my practice. It also allowed me to collaborate with OBGYNs who we don't normally think of as like a great referral base, but they make up the majority of my referrals. I get more from them than family medicine doctors.
Wow. I think they're certainly untapped in a lot of practices because I really hadn't thought about it in this way until today.
Well, they do not want to manage diabetes and hypertension. That's another thing. They do not want those patients in their practice. They want it cured.
Got it. There was a comment in the Q&A or a question about, are these observations equivalent for both the sleeve and the bypass? And that was about 10 minutes into your talk, Dr. Hilton. Maybe in terms of lactation outcomes, or do you sway a patient one way or another if they're breastfeeding between one procedure or the other?
There's no literature on that. Again, there's a sparsity. I think that would be a really great randomized controlled trial, but oh my God, the numbers needed, we'd never be able to do it, right? So these are all just going to be observational or retrospective. For me, honestly, I think I have better fluid control in post-op bypasses. My sleeves puke more than my bypasses. Maybe my sleeves are too tight. I don't know. But when I talk to other surgeons around the country, the refluxing and the vomiting does tend to be a little bit higher immediately post-op after a sleeve. And again, when we did the bypass on this other patient, she was able to maintain fluid. She was able, and even with the internal hernia, was able to maintain her supply, but she did have to supplement. So I think goals are important, right? Like for me, I wanted entirely breastfed babies. I don't know why, but I had this just complex about formula. Fed is best. It doesn't matter what you're feeding your baby, just feed your baby. That's the conversation we need to be having. If you want to keep breastfeeding for, the relationship, the bonding, there's still, immune properties that you're, transmitting to there's lots of reasons to breastfeed. Again, I don't want to make this like pro breastfeeding talk, but if they want to breastfeed, even if they can't only feed their child with breast milk, they can still breastfeed. They just may not make enough milk to solely do it.
Gotcha. That's great.
I was curious, you were mentioning for endometrial cancer, the study you're doing in your institution, looking at endometrial biopsies, I think preoperatively. Were there any, and this is all pre-op, so do you have any post-op data on them after you go to surgery? Any differences there with the procedures? Just
So
curious.
we're gathering that data now, Shaina, because we've been doing this for 3 years. So the
Mhm.
first thing that we presented at ASMBS was 2.5 years ago. We presented our initial first 6-month data, which was, does this even work? Like, is there even any interest?
Yeah.
And yes, there was a lot. And we found we were doing office procedures on almost half of the women that we were referring to her. So we now have women though that post-op, they stick with her. They're coming back in for more, more testing, or they're getting their annual pap smears, and they actually have an established women's healthcare expert. That's what I want to prove. I want to prove that these women that had endometrial hyperplasia pre-op, when we biopsy them post-op after bariatric surgery, they no longer have hyperplasia, because that's the goal, right? We want to prevent progression of cancer. There are small case studies that show stage 1 endometrial cancer can be treated with an IUD and metabolic surgery alone. They have put women into remission with stage 1 cancer and preserved their fertility. Because, and some of you may be asking, why does this matter? The treatment for endometrial hyperplasia and stage 1 cancer in the past has been hysterectomy. And if you're a woman who's 25 years old and you want to get married and have kids, like, for me, that would have been a sentence that would have been unbearable to hear, taking my childbearing, ability off the table. It's a really important thing for a lot of people. Some people may not care, but others will. So offering them fertility sparing options for hyperplasia and stage 1 cancer was huge. We've even done metabolic surgery at the same time as TAH-BSO in a patient that already had progressed cancer, because even if they already have progressed cancer, remission rates are lower after bariatric surgery. So we spun the robot. We docked straight across. She did the hysterectomy first because my opinion was cancer trumps metabolic surgery. Let's make sure there's no complications. She did a hysterectomy safely, and then we just undocked, spun Roxy. That's what we call a robot. And we then proceeded to do a bypass. And that patient is in full remission 3 years later and has lost like over 100 pounds. Her diabetes is gone. I get letters from her all the time. So I feel like we're doing profound things with our OB partners.
And in my previous institution, we were doing similar things, trying to figure out ways out to partner, especially for endometrial hyperplasia. And the combination cases, we did a few and actually have studied the cost, and the cost benefit to the patient's pretty profound, partly because you're saving them two surgeries if you're going to do it. Going to do the hysterectomy at the time of bariatric surgery, but also the cost benefit for their cancer care was actually pretty profound.
Absolutely.
Wow.
And it's just the right thing to do. Like, I hate when I feel like as bariatric surgeons, we constantly justify or have to justify what we're doing with cost, right?
Mhm.
And it's like, we know we are cost effective, but it's still frustrating. We're also life effective.
Yeah. But Dr. Peterson, the stats that were shown regarding us as metabolic surgeons not really even asking these screening questions for women who come in. And I know I really haven't done a great job of that. And this talk was a reminder, but maybe for our fellows, do you have a script or certain specific questions you just asked during the interview efficiently just to capture a woman's kind of screening history and health?
Yeah, no, that's a great question. We do, and I think early on in my fellowship, we asked those questions, and so I carried it into my practice. We actually have something we've termed it our passport to surgery, which is basically the checklist of all the things that they need for their insurance requirements and this and that. And included on that is the health screening. So, I always ask them if they had their colonoscopy, and some people it's not even been discussed with them before. Pap smear is one of those things. And so, yeah, it actually helps me. I've been doing this for a while, but it does help remind me if I'm like, oh, dang it, I forgot to ask that question. I go back in and, as I'm about to do my little checklist. But I think it's really important because, again, I'm not sure. One of the things we actually debated in our practice was how often does that change anything for us? Like, does that change going forward? But the reality is, again, you're the first person maybe that's seeing them, and to Renee's point earlier, their OBGYN and, their OB might be their GYN might be their primary care. In fact, they often are. But we're not trying to create more barriers to get to surgery. So it's not like, well, you have to do one more thing before you can have surgery. But the reality is that it's a really important screening thing to do. Mammograms. So we've picked up breast cancers. We picked up endometrial cancer. by requiring those things before because they weren't going to be checked. And so I think that's a real challenge too, right? You have to be aware because the last thing you want to do is do surgery and do a gastric bypass on a patient or a SADE or something like that, and then now they have to be on chemotherapy for a breast cancer or something to that effect. And we don't know. We're not great about knowing how well sort of the oral chemotherapeutic agents are in terms of their absorption after some of these surgeries. So you don't want to put them at a higher risk. So I think it's fair. You should ask it up front. And it's normal screening, for patients in that age range. So.
Yeah, absolutely. And I think this discussion really just highlights what an important role we can have, because the obesity stigma is very real and patients already come with a ton of shame, and it's already hard to get them to our office. And we really may be the first ones really asking them some of these questions because they're too ashamed to go to some other providers. And so I always talk about the stigma, and I discuss it with my patients and make sure, we can talk about the discomfort so that we can get to a lot of these screening questions and make sure they're well overall. So.
And I
Yeah,
feel like
Rickesha, I think-
identifying your OB partner who's going to be aware of that stigma is important. My patients love Dr. Titus. I did a woman on purpose, and the male that helped me create this program, the male OBGYN, was very, very insistent. He was like, you need a woman. He said, I'm just telling you, there's a lot of women, especially women with obesity, may not be comfortable with the man. And I think he was right on that, because a lot of these women ask me immediately, is this a female provider? I mean, you're asking these women to be incredibly vulnerable, to go into an office with a stranger they've never met when they're already vulnerable about any kind of exam, and do a pelvic exam. I mean, there's nothing probably more vulnerable than we do in healthcare than something like that. And she doesn't even address their obesity. She talks to them only about their OBGYN care during the visit. She never talks about the fact that they have obesity or that they're overweight. And that means a lot to the patients. They actually have written me letters or letters to her and said, you're the first provider that I've ever seen that didn't blame everything that's going on with me on my weight. She waits until the very end of the interview and she says, now, lastly, congratulations on taking this step to treat your obesity. This is really going to change your life. Such a great thing you're doing. She doesn't even bring it up until they're ready to walk out the door. Everything else is about them being a woman and what they're there to talk about. And I think for my patients, they need that. They love that. The stigma is real. It is for a lot of these women. They've been 20 plus years without getting a pap screen because they're just so embarrassed.
Wow. Incredible. Dr. Peterson, you were going to say something?
Oh, I was just, I was going to highlight, actually, to be honest, I kind of forgot what I was going to say with there. But no, I mean, I agree. I mean, this is a really important, we are, as providers, again, we're able to have that conversation. I'm trying to remember what I was going to say. We're able to have that conversation easy, it's not an easy conversation to have. And, we don't just say, we don't address their obesity as we're walking out the door. Right. It's the first thing we're talking about, but we tend to be more compassionate about it and empathetic with our patients. So I think that's important. It's why they trust us, and having those partners that we can refer to, because we may be sort of the first, providers that they're getting to have that trust within the medical care area.
Absolutely. And there's one more question in the Q&A. Any changes in vitamin supplies if women get pregnant after 1 month? Post-op?
Yes. So we check everything. Some have to be adjusted. Some of the bariatric vitamins are too much. You don't want to overdo like vitamin A. I think it's vitamin A. Again, this is why I do everything with my dietitian team and a high-risk OB. We look at every single vitamin they're taking, and we double check it with this high-risk OB. Sorry, naturally an ambulance is approaching the hospital right now. It's making a lot of noise. Hopefully you guys can still hear me.
Yeah.
So we look at everything with them. We do tend to increase folic acid and vitamin D. All of my patients are vitamin D deficient. I feel like every human pre-op is vitamin D deficient in Georgia, myself included. There's not enough sunshine or something, but so we check all of those things because, again, folic acid is the big one, 1 month post-op. The scary thing about pregnancy is a lot of times by the time our bariatric patients recognize that they're pregnant, they are past the window of organogenesis, and you may have missed the mark to prevent any of this. So it's important that they're at least taking their bariatric multivitamin at a minimum. And then we're blind to it as physicians. I ordered a small bowel follow through on a bypass and I'm a woman who's had 2 babies. This woman came in and told me I'm throwing up every morning. And I was like, oh, it must be my bypass. Dadgummit, my anastomosis must be too tight. And I ordered a small bowel study on her, and they said, we can't do this, Dr. Hilton, she's pregnant. So I didn't even think about pregnancy. And so just again, broaden the mind.
No. Well, excellent. I think we're at time. It's 8:01. And so thank you everyone for engaging in the chat. And I know Dr. Eckhouse will have the PM session later for more discussion.
Yep, it'll be 3:45 3 p.m. Eastern, 12 p.m. Pacific for those on the West Coast. We look forward to seeing you guys then with Dr. Julianne Lloyd.
Come to our session in San Diego. You can ask more questions live.
Yes.
And definitely do that. I know I have a ton of questions that I'm going to be asking you guys at the session at ASMBS. Thank you so very much.
Yeah, thanks everyone. I'll be there too next week for sure.
Thank
See
you
you all
guys for
soon.
having us.
Thank you.
Bye.
I'm wondering, Julie, if we can unmute her. It looks like her thing is muted.
Yeah, I'll also send her a message in the meantime. But I think she brought up one of the best cases I think possible to really look at this stuff, having a pregnant patient who has nausea and vomiting, because we always default to thinking that it's hyperemesis. And I think in a bariatric patient, we have to always consider that it's a bowel obstruction. Have you had to operate on any of these patients before?
Yeah, actually, I have, and I think that's the tough thing when I'm making the decisions about a patient who's in this age group and wants to have surgery. It's after gastric bypass. I have concerns for this happening, and it's happened a few times. So, and I think we all know that you can't really just sit on that, and that's the hard part. And especially when you get a CT scan like you see in the last area, you really are obligated. You don't have a choice. Now, I know this one was in the 4th trimester, as she had described, but I've had it in, the 2nd trimester as well. It's just a little bit of, additional pressure in the abdominal cavity. That's kind of how that goes. I do think that is can potentiate that hernia formation, certainly. And so I don't know, I don't think it's chicken in me. Maybe it's just becoming the old guy in me who's like, a sleeve might be a better option for that group just because of this concern primarily, especially if they want to be that, definitely want to get pregnant. I don't think that's necessarily a bad thing, but it definitely is in my algorithm when I am talking to a woman of childbearing age and talking about different types of surgery. I also think that when I think about the surgeries themselves, the gastric bypass is a terminal operation, and I would say, my practice for a long time was about 50-50 bypass and sleeve. Now that I do other operations like the SADI, I do kind of see the sleeve as either one and done or a gateway entry to a later operation. And so I feel like it's a little bit safer in that sense for that population.
So when you're counseling patients, and let's say a patient comes in and says that they want to have a SADI, is that a part of the discussion as well in terms of your operative plan?
It is, because I do worry, I actually, we've had one internal hernia after a SADI, which, everybody says, oh, you don't get internal hernias. Yeah, you do. Yeah, it happens. And it may be less frequent, but it can happen. And that didn't have anything to do with pregnancy, but that having been said, I any of the rerouting or the things that we're doing, I definitely want to have that as a consideration when I'm talking to a patient about pregnancy and what their plans are going forward.
Most, actually all of the patients who come into our practice and who become pregnant after bariatric surgery, we send them immediately to the high-risk OB. And I would say probably one of my concerns is, trying to maintain their nutrition in a patient who's pregnant and who's had a SADI, because that's already kind of a little bit of a challenge. you know, I haven't had that experience, fortunately. I would say probably my experience with pregnancy is that I've had a number of patients get pregnant within the first year of surgery, kind of unexpectedly, the oops moment.
Yes.
Do you know how long it takes for the fertility to recover?
You know, I've seen it very quickly. That's the thing. I'm like you. I've had that oops moments with patients, and we counsel everybody about that. And I would say in the unfortunate situation of those, you know, patients who want to, you know, have children, after the bypass is where I saw the more difficult situation because they became pregnant, you know, at 2 to 3 months after surgery. Most of those patients didn't carry a baby to term. Couldn't support both the fetus and their nutritional needs. And that's kind of why I've always pushed for more 12 to 18 months after surgery when they want to do that. So, you know, again, I think it's a challenge for sure for those patients. But to your point, or to your question, really is that fertility comes back so fast. I think it's a surprise for people who have been trying for so long and have not had success. So just part of their normal, and then all of a sudden, it becomes a very big change.
Yeah. Do you know if it's just the weight loss that leads to this change, or is there something specific about bariatric surgery?
You know, I don't know. I would have to suspect that the hormonal changes, you know, certainly play a role. I'm not sure how much the weight, you know, other than it as an inflammatory, you know, response, I think overall. But you know, Renee may have a better answer to that if she was on. But I definitely am sure that the hormonal changes are a big part of that.
Yeah, it makes me wonder a little bit whether we'll see similar effects for patients who are on anti-obesity medications, if they'll also have an improvement in their fertility. I guess it's still relatively early for us to know.
Well, yeah, and to Dr. Hilton's point, in the, you know, when we were talking earlier in the first group, and she finished, I think it was on the last part of that. You know, don't give AOMs to patients who, you know, are wanting to become pregnant. And so you know, I wonder, and I do worry with that, to your point, if the fertility improves with their weight loss and they're on those medications, what happens? That, you know, they're going to have to stop or maybe not carry the baby to term. Those are the choices, I suppose. And that'll be a challenge and a frustration for a patient, right, who is losing weight, is excited to be pregnant, but now has to stop the medication. That just it almost puts us in that access to care problem where we've had patients who, you know, Medicare just changed their thing where they're you know, for patients getting it for weight loss, that's great. But when they switch over to that, it's not covered as a weight loss med, only for diabetes. And so people who are doing really well now no longer have coverage for that. So I guess it's sort of a similar thing if you had to stop it.
Yeah. Well, it looks like we don't have many questions from the audience. I would like to invite you guys. I know we have a small group today, ASMBS next week, and everybody's kind of getting ready. But if you have anything to post now, because I think it's fine for us to end a little early with Dr. Hilton not being able to join us. Yeah, okay.
Good.
All right, Dr. Peterson, thank you so much for being
Thank you.
on again. Really
Yeah.
appreciate you, and I will see you in a couple days.
You bet. All right. Have a great one.
All right, take care.
Bye-bye.